Hello and welcome. I'm Autumn Lafretta, the Education Manager at the Foundation. Thank you for joining our Answers from the Experts Q&A. We are very excited to have you here. Before I introduce our panelists, I'd like to go over some housekeeping. The questions and answers, please add your questions in the Q&A tool in Zoom. That way we can get them responded to as fast as possible. We will be recording this video and it will be available on the Foundation's YouTube channel in a few days. Upon the conclusion of the webinar, there will be a survey that pops up on your screen as you exit. We would really appreciate you taking the time to complete the survey. We would also like to thank our individual donors and our funding partners for making programs like this possible. Now I'd like to share some information on our speakers for today. Dr. Ellen Kim is a professor of dermatology, and she is also the director of the Penn Cutaneous Lymphoma Program and vice chair of dermatology clinic operations at the Perelman School of Medicine at the University of Pennsylvania. We also have Dr. Lauren Pinter-Brown, who is a board-certified, fellowship-trained UCI hematologist-oncologist who specializes in the diagnosis and treatment of patients with cutaneous lymphoma. So let's please introduce our panelist. Dr. Kim, thank you for joining us.
Thank you, Autumn. So happy to be here.
Thank you. And Dr. Pinter-Brown, we appreciate you being here.
Thank you. It's always a pleasure.
Before we get started, I do want to say one reminder that Dr. Kim and Dr. Pinter-Brown are sharing their opinions based on their experiences. So please do not take any of the answers they give to your questions as a second opinion. You should always follow up with your treating clinician. So let's go ahead and get started. Jump in with our first question. Please discuss the advantages, disadvantages of steroid ointments versus non-medicated ointments. Should steroids be used regularly or only during flares?
So topical steroids are a mainstay treatment for all cutaneous lymphoma, T-cell lymphoma patients, and most people use it for flares regularly, and sometimes it takes a few weeks or even a month to get the flare under control. But in general, you do want to take some breaks because topical steroids can cause some skin thinning if they're used day after day, month after month, and thin skin can bruise easily and get tears. So we do recommend breaks. And given that, if you find that topical steroids are not enough to control your skin T-cell lymphoma, then non-medicated topicals can be useful for long-term management. But some patients are actually on both because topical steroids work fast. That's the main advantage.
Dr. Kim, could you address the use of like moisturizers or emollients in patients with cutaneous T-cell lymphoma?
Yes, they're incredibly important, and we recommend that you follow a gentle skincare regimen and moisturizers. There are differences in moisturizers. We generally recommend a thick cream or an ointment-based moisturizer rather than a lotion. Most patients initially use a lotion and it comes in a bottle. It's very easy to put on quickly and it dries quickly, but it's actually not very moisturizing because it has a high alcohol content. So we want patients to use a cream or an ointment.
Thank you for that additional information. Our next question. Are there recent advancements in staging and treatment of folliculotropic MF?
Now, this is a very up-to-date, sophisticated question, and I'll try to tackle it first, and Dr. Pinter-Brown can pipe in. So folliculotropic mycosis fungoides is a subtype. It's about 5% of MF patients who have the MF going around the hair follicle. That's why we call it folliculotropic. And it can be a more stubborn and an itchier variant on average. And because of that, in the past, we used to think that because it was deeper in the skin and it's more stubborn, that the prognosis was worse. But there have been a few studies recently showing that folliculotropic mycosis fungoides, there are milder manifestations, intermediate and more severe manifestations, both clinically and on biopsy. And the patients with milder manifestations may have indolent or what we would call low-risk disease. So that means that not all folliculotropic mycosis fungoides has a worse prognosis. So that's a good observation, and essentially your doctor will be able to look at your skin, look at your biopsy, or discuss with your dermatopathologist, and depending on that, may be able to refine what they think your folliculotropic mycosis fungoides, where it falls on that spectrum. Dr. Pinter-Brown, do you have any other comments?
It's a very good answer, and a very controversial topic, I think, something that we need to learn more about over time, and kind of refine how we think about folliculotropic mycosis fungoides and its treatment.
Okay, thank you both. Next question. When patients are being treated with a systemic therapy, oral or injectable, but still have a few bothersome patches or plaques, do you offer a topical treatment in addition?
Most definitely, most definitely. And I think we can both answer this, right, Dr. Pinter-Brown? So I would say that topicals are important, are the main player in early stage disease, but even in advanced stage disease, it's useful to have it as adjunctive treatment. And so I would say that it's very common for patients to be on the combination treatments.
Agreed. I think that a lot of times when someone's receiving systemic therapies for more advanced disease, there might be recalcitrant areas that are patches or plaques, and we certainly prescribe topical treatments for those areas.
Great, wonderful. Is there any early indications at diagnosis which can predict who's going to progress from stage 1A to advanced stage?
There's a really old landmark trial from the 80s that looks at people, which are very few in number, 2%, that progress after early stage disease. They tended to be older patients and patients who did not respond to their first treatment modality.
I would agree with that. There are sometimes histologic features on the skin biopsy, something called large cell transformation, which is something that's observed on the pathology report that sometimes can indicate worse prognosis. And I agree with the more like diagnosis at an older age. Dr. Pinter-Brown, do you have like what that older age would be?
No, I'm trying to think in that paper. I want to say, sadly, it was in the 60s. It's an old paper. I haven't read it in such a long time, but I vaguely remember in the 60s.
All right, thank you. What percentage of people with Sezary get a second malignancy, and how long after diagnosis? In addition to that, is there an updated life expectancy with Sezary?
I love the second question, and I wish there was, because it's certainly not what you would see if you looked on the internet. So don't even look, because it's so far off of reality at this moment. But secondary malignancies, all patients who've had a diagnosis of lymphoma have a slightly higher incidence of other lymphomas. They don't have to be T-cell lymphomas, and they don't have to be skin lymphomas. As well, there's been quite a lot of epidemiologic studies looking at patients with cutaneous T-cell lymphoma that suggest perhaps an increased incidence in certain malignancies, like colon cancer. All patients with lymphoma have an increased risk of kidney cancer and melanoma. But there's the risk is not hugely great over the general population, and there's no period of time with which you would be concerned about secondary malignancies. In fact, the secondary malignancy may precede the diagnosis of cutaneous T-cell lymphoma.
It's really good information. Thank you.
Can I ask a follow-up question? Do you have recommendations, Dr. Pinter-Brown, about how to monitor for such things?
I think really with history and physical exam, I definitely wouldn't advocate screening with radiographic studies like PET scans or CTs. I think that in a patient who has lymphoma, any complaints that sound like what we call B symptoms, fevers for no good reason, profuse sweating at night, or a significant weight loss for no particular reason, lymph nodes that could be felt or seen, should be pursued. And certainly any skin lesion that looks like melanoma, that's true for anybody, though, really. We wouldn't, just kind of pass it off. But other than the person being aware of their symptoms and communicating them to a physician, and their routine physical exams, which they're going to get because they're being seen by a physician, I wouldn't advocate anything else, including blood draws.
All right, that's really good, thorough information. Thank you. Next is about skincare, which we have a few of these coming up. Is how does moisturizer help people with MF, and how often we should moisturize?
So moisturizing is that is a common question, and when the skin barrier is affected by dryness, that can cause and trigger more inflammation and result in flares of a variety of inflammatory skin conditions. Eczema gets worse with dry skin, so does psoriasis. Many patients during the wintertime, you can have flares of your eczema or psoriasis, and that also applies to mycosis fungoides, CTCL. So moisturizing is really, really important. We recommend definitely doing it at least once a day after a shower while you're still a little damp. As I mentioned, use a cream or an ointment. And then you may need to do it a second time of day if you live in a cold, kind of dry environment. And I know this is hard. There are some people, and I don't want to generalize, but some men, it's not part of their routine to put topicals on their skin. But once you have the diagnosis of mycosis fungoides, it is very helpful to pay attention to it and moisturize regularly.
Thank you. Next question. My husband has MF, diagnosed 6 months ago, stage 3. He has had full body radiation and is now on Bexarotene. The itch is far less bothersome and his skin is sometimes clear, but we are finding that he gets rash flares every few days and they resolve themselves in a few days and then another one comes. Is this expected? In your experience with your patients, are you seeing this often?
Unfortunately, I wish we understood what rash flares means. I can think of some situations where you might have skin lesions that come and go. They may not be the mycosis fungoides. I'm not sure we have enough information to answer the question.
So the person asking the question is live with us. So if you could put some additional information on what you mean by rash flares, then we can get a better answer for you. Okay. Is there an optimal amount of time for full body direct sunlight?
Well, that hasn't been formally studied in an objective study or trial. I can tell you what I recommend to my patients. So ultraviolet light, whether it's natural sunlight or in-office phototherapy, has a direct biologic effect on the cutaneous T-cell lymphoma cells in the skin, and results in them, dying off and going into remission. So patients with mild disease, natural sunlight sometimes can be very helpful. I usually tell patients 10 minutes of natural sun a day on a kind of average sunny summer day in Philadelphia without sunscreen. But if you're going to be outside more than 10 minutes, then you probably want to put sunscreen on your face and head and ears, and just monitor and be a little careful because if you're out all day at the Jersey Shore, for instance, then you may get burned without sunscreen. So those are my recommendations.
Dr. Kim, do you ever have patients put oil on their skin before they get natural light?
That's a good question. I haven't told them that formally, but what you're alluding to is that moisturized skin or oiled skin, the light penetrates better, and that we do tell patients to do that before in-office phototherapy, that to apply oil, because really dry skin, the ultraviolet rays can't penetrate as effectively.
I think the other
That's interesting.
The other caveat would be that you certainly don't want your patients to burn, and each person's skin might be able to tolerate a different amount of light. So in some ways, the amount of light, natural light exposure, well as in-office phototherapy, would be determined by the patient's type of skin and prior tanning history.
Yeah, absolutely. So that if you never tan and always burn, then I might say 10 minutes might be too much. But for patients with, darker skin types, you might tolerate much more. And then, of course, an important point I forgot to mention is if you have a history of skin cancer, melanoma, really sun-damaged skin, then it may not be advisable to seek out natural sun without, some guidance from your primary dermatologist. So really, this is just general guidelines, but ultimately your primary CTCL doc should give you recommendation.
Okay, thank you. I do have a follow-up on the rash flares. So what she put is that we see rash return on his torso, side, arms, and back. So the
Well,
original question was that he's flaring up, going away, flaring up, going away, coming back.
so I hate to waffle on this, but stage 3 to me would be someone that has red skin all over. And so I'm wondering if what the person is saying is that they had total body red skin. It was radiated, but now they see red skin again. I'm sorry. The situation isn't clear enough for me.
So if we can get some additional information, then I'll come back to the question.
And
All right. Yep. Does brentuximab carry long-term side effects?
the biggest side effect from brentuximab vedotin is called peripheral neuropathy. It usually manifests as numbness or pain in fingertips and tips of toes that then kind of, as it goes on, progress up the hand or foot. That can be reduced by reducing the dose of the drug and sometimes even lengthening the time in between doses. And I would say that is the biggest long-term toxicity of that drug.
Okay, thank you. Is topical steroid enough? Does not doing any therapy alter the course? And we're going to have a different question later that's kind of along the same path.
I think it's important to clarify what stage you are. That I think is pretty important. I think most of us feel that for very early stage disease, particularly stage 1A, and if you have patches less than 10% of your body, then what we call active observation or surveillance, active surveillance, can be acceptable. And it is recognized on certain treatment consensus guidelines, like for instance, the ERTC ESMO guidelines. Because for early stage disease, truly early stage disease, we don't have great data that being aggressive about treatment in that patient population changes overall survival or decreases the risk of progression. For anything above stage 1A, I would say that it really depends on the patient, their disease tempo, if they have patches or both patches and plaques, if they have a history of infection, if they have severe itching. All of those factors play a role in the doctor's recommendation to treat. Because if you were severely itchy, scratching your skin, you're at risk for infection, and then treatment would be very important to get that itch under control, because we don't want you to get infected. But as I circle back, for selected patients, active observation, or at least periods of time, if you have very minimal skin activity, is okay. If I circle back to topical steroids, is it enough? For some patients, yes. I would say in my practice, about 1/3 of my early stage patients are managed with just intermittent courses of topical steroids and periods of active observation. But that means 2/3 have to move on to something else.
Okay, thank you. We're going to have a couple of, oh, that's after this one. I'm getting ahead of myself. Is there any differential utility to knowing the type of LYP one has?
I don't think so, but it's so important pathologically because there's more aggressive actual neoplasms, actual cancers that can mimic different types of lymphomatoid papulosis. So really, to me, where it becomes most important is differentiating between lymphomatoid papulosis and some of those other conditions.
Right, thank you. And where I was getting ahead of myself, we have a couple more questions related to phototherapy and a follow-up to the last question that you asked. So do you recommend photolight therapy as preventative treatment? How effective, and would you recommend it to younger patients who would be getting the treatment for a long period of time?
Today in 2024, we do not recommend that. I think many, many years ago, there was a bit of interest in that concept, but especially for young patients, if you get phototherapy week after week for many years, then you increase the risk of chronic sun damage and increased risk of skin cancers and melanoma. So long-term phototherapy for either prevention or as maintenance indefinitely, that shouldn't automatically happen. It is true that some patients, after they do phototherapy for their CTCL, if they had very difficult disease to control to begin with, then your doctor may recommend a slow taper and a maintenance regimen of once a week, once every other week. Sometimes for PUVA phototherapy, you can even do it once a month or once every 8 weeks. But those are selected patients, and your doctor will weigh all of the factors before they make that decision.
Okay, thank you. And so back to the question about full body sunlight, when we had talked earlier about going out in the sun, should you be directing it mainly to the areas involved or the entire body?
Well, it depends. I would suppose if you have very limited, like just 1 or 2 patches, you could just expose those areas. The tricky thing about CTCL, though, is that it often then once it retreats from the areas being exposed, sometimes it likes to run and hide in the covered areas. So what I usually do is it depends on the patient's body surface area of patches and plaques, and also just what those patches and plaques are doing. Are they just sitting there? Are they moving frequently? But in general, when we actually prescribe in-office phototherapy, we recommend exposing the whole body because there is this tendency for the condition to start to travel to other areas that are being shielded from the light. But the face, because the face is usually not affected in most CTCL patients, if it is not affected, you can certainly shield your face and wear a hat. And, in the office, we shield the face with sunglasses and sometimes a pillowcase or a towel.
And another reason I think that sometimes we treat the whole body is that some skin lesions are not so obvious to the eye. And so you might notice that when you take a shower or do something that increases the blood flow through your skin, that you see additional lesions. And then as your skin cools down or your heart rate slows, the lesions become less visible. So if we just treat areas where there's obvious skin lesions, and there is what we would call like a subclinical, a skin lesion that you can't actually see so well with your eyes, but is there, and we don't treat it, then that would lead to you then over time seeing skin lesions in other areas and kind of playing whack-a-mole, having to go around treating all different areas because skin lesions are popping up.
I agree with that.
All right, thank you for that extra information. So this was a follow-up about the oil and the cream. Can you elaborate on the in-clinic or home therapy UV protocol? It's the first time they're hearing about oiling or creaming the skin first.
Oh, sorry about the background noise. So just to clarify, in the office, some patients do receive phototherapy without any pre-treatment oil or cream. And then the other offices do use the pre-treatment oil and cream. And it really depends on how scaly and how thick the scaliness of your lesions are. So there are some CTCL patients, if you have no flaking or scaling at all, then creaming and oiling before phototherapy, even at home, is probably not necessary. But if you have quite a bit of scale and it's thicker, then you should probably moisturize, not sunscreen, but regular moisturizer or oil to help the light penetrate better.
I think a common question people ask is what kind of oil? I always tell them it can be any oil. They could go in their pantry and use olive oil or baby oil. But what do you tell patients, Dr. Kim?
Yeah, I think I would absolutely agree with you. It doesn't have to be anything specific, as long as it's not heavily fragranced. So definitely not some type of aromatic or botanical oil, because there's often hypersensitivity to that.
Okay, thank you. I was diagnosed with primary cutaneous anaplastic large cell lymphoma in 2018 and again in 2020. What is the likelihood of a recurrence of the disease now that it is 3+ years since the last event?
I don't think there's an actual number, but primary cutaneous anaplastic large cell lymphoma has a very high recurrence rate. So I would continue to be observant of skin lesions. As well, there's an association with other skin lesions like lymphomatoid papulosis or mycosis fungoides. So if there was any skin lesion popping up that you don't have a very firm idea what it is and what the plan is, I would definitely show it to your physician.
Thank you. For someone recently diagnosed with stage 1 MF, what are the key first steps to take? Certain doctors to see, baseline testing, etc. This is a pretty common question on who to see and when.
In the ideal situation, your dermatologist, who usually is the one who diagnoses it because it's based on a skin biopsy, if they have experience with it, then but in the ideal situation, we would recommend being referred to a specialty center to confirm the diagnosis. Mycosis fungoides, as Dr. Pinter-Brown alluded to, sometimes on the biopsy can overlap or mimic other conditions. So you want just confirmation of the diagnosis by an expert who also examines your skin and does clinical pathologic correlation. They'll also examine your lymph nodes. That's an important part of the exam. Sometimes that's not done by a local dermatologist. There are some places where such a dermatologist doesn't exist, and there are oncologists, medical oncologists, like Dr. Pinter-Brown, who serves as also sees early stage patients. But as long as it's somebody who is familiar with and an expert and up to date with the recommendations for staging and treatment. In my clinic, early stage disease, we keep it pretty simple in terms of the staging. So if you have patches or plaques less than 10% of your body, and we do not feel any abnormally enlarged lymph nodes when we examine you, and if you don't have those B symptoms that were mentioned, unexplained fevers, chills, drenching night sweats, severe progressive fatigue, total body itching, then I will order a basic blood panel of a complete blood count, a metabolic panel, and something called lactate dehydrogenase. We also sometimes order 2 viral tests, HIV and HTLV, not because they're the cause of mycosis fungoides, but those are viruses that can sometimes cause rashes that mimic mycosis fungoides. So it's good to rule those out. And then imaging is really not necessary for, the scenario I just described, unless we find something abnormal on blood work. Bone marrow biopsy also is really just not done for early stage patients unless we find abnormalities on the complete blood count. And then, do you have to see an oncologist with early stage disease? If you see a dermatologist who is familiar and expert in CTCL, then it's not necessary.
I would really echo what you've said, and I will say for my colleagues that are hematologists, oncologists that aren't so experienced, that frequently I see early stage patients that have PET scans and bone marrow tests because that's what we're used to doing for other kinds of lymphoma, but it really isn't necessary here.
Okay, thank you both for that thorough answer. Next, does recurrent folliculitis in a patient of MS also suggest a possibility of follicular MF?
It is possible, but it is also true that MF patients can get more frequent bacterial infections like folliculitis. So sometimes you can't really tell clinically whether it's folliculitis or follicular MF. You can get follicular MF that looks exactly like folliculitis. So generally, when I have a patient like that in my office, I like to do a bacterial culture of one of the pustules if you have a pus bump, and then to rule out bacterial folliculitis. And then sometimes we also just empirically treat with topicals to treat the bacterial folliculitis. And if it goes away, then you kind of have your answer. But a biopsy can also be very helpful. So if it's not getting better with simple things, a skin biopsy should show whether it's follicular MF.
Thank you. Have other patients reported immediate correlation between mental stress and the manifestation of lesions?
I think that's such an interesting topic. So there's some very old data that shows if people are stressed, it doesn't have to be just mentally stressed, but things like divorces, loss of job, move, death in the family, that your immune system is impaired transiently. And certainly with all slow-growing lymphomas, be it B or T, there's an interplay between the patient's immune system and the malignancy. So I have to say that I have observed throughout my career, not infrequently, that if a patient has a stressor, that their skin gets worse. And if I do nothing in particular but wait for the stressor to pass, their skin then improves. And I see the same thing in follicular lymphoma, which is a slow-growing B-cell lymphoma. I think it's such an interesting area and might tell us a little bit about what patients can do to help themselves fight their cancer the very best their bodies can.
I completely agree. I think stress is not the cause of the mycosis fungoides, but certainly can trigger flares. And I agree that it's interesting to see. And I know it's easier said than done to manage stress, but it can contribute.
What treatments are available for cutaneous T-cell lymphoma Sezary with TP53 deletion?
That's a good question. So if we look at TP53 deletions across the board in lymphomas, B or T, the message is that conventional chemotherapies don't work so well. And thankfully, we don't use conventional chemotherapy very often for cutaneous T-cell lymphoma and specifically for Sézary's. So I would utilize the knowledge about a TP53 mutation in the same way that I do for other lymphomas, and that I would tend to use therapies that aren't conventional chemotherapeutic agents.
Thank you. Next question this is a good one. Are there any permanent solutions for itch?
Yeah, this is a very, very important topic and one where we need more options. Well, so there are treatments that the most important thing is to treat the underlying mycosis fungoides cutaneous T-cell lymphoma. Whatever cutaneous lymphoma that's causing your itch. Treating the underlying cause is really important. But it is true many patients, even if you are actively treating the lymphoma, you can still have quite difficult itch. So there are topical things that you can do. There are oral systemic therapies you can do, and on the horizon, probably some IV therapies. But none of them are quote unquote permanent. What I would say is treating your underlying disease is the most, if you get into remission, then that will hopefully be durable and long lasting. Some of the things we use commonly for, oral agents are like antihistamines, things like gabapentin or pregabalin. We also use some low dose of antidepressants like mirtazapine. There's even anti-nausea medicines like aprepitant. So we have a lot of tools in our toolbox, and it's a matter of just trying them. But I know that we probably need more.
Another
Thank you.
aspect is, I guess, two comments. One is back to the moisturizers, because if you have dry skin, it itches like the devil. So that's not so helpful. And number two, if you listen to Dr. Kim, a lot of the treatment options that she's mentioned aren't antihistamines that people would generally think about when they're treating people with itching. And the importance of that is that the itch pathway in patients that have cutaneous T-cell lymphoma is really mediated by nerves. So a lot of the drugs that she mentioned are things that neurologists use for other purposes, instead of things like Benadryl or drugs that oppose histamine, because the pathway here with the itching is very, very different than in other conditions.
It's a really important piece of information on that, because you wouldn't actually think to take something that's an antihistamine. So this one is kind of a two-parter. I'm 74 and I've had MF for 25 to 30 years. Last year I noticed small to medium-sized patches appearing everywhere. I have chosen not to pursue treatment. So the question is, if I continue to not treat, in your opinion, could the patches turn into plaques with more blood involvement or possibly turn into another cancer? How may I stop rapid progression? Does it matter if your skin is covered with patches on 8% of your body? They're lucky that they have minimal itching with this type of involvement. So just kind of an overall, what is your opinion based on what you have seen on how it really impacts? And Mike, if you could leave the question up as the doctor answers so that she can see all the pieces to it.
How about we tackle the easy ones first? Will it turn into another type of cancer? No. That one's fairly easy. Will you get more blood involvement? Probably not. All right, now we're getting to the harder ones, right? Could the patches turn into plaques? They could. Does it matter if your skin is covered with patches 80%? Dr. Kim, that would be a great question to answer when you were talking about skin barriers.
Yeah, again, I think both Dr. Pinter-Brown and I would love to lay eyes and see what the skin rash looks like, because, or the extent of disease, because that does influence us a lot about who we think it is fine doing active surveillance or nothing, and others where we think that could be an issue and not to your benefit. But I think it's reassuring that for 25, 30 years, you've felt fine. And I guess my only question would be if you feel like the tempo of disease, the trajectory of the disease, that's an important factor. If it's very slow moving, not spreading quickly, that's reassuring. But if it's covering over 80% of your body, I think that is a little bit worrisome. And those patients often are itchier and also often are at higher risk for, slow or involvement of the blood at a low level. But what we also talk about is this disease is very heterogeneous. And it's one of the struggles we have in managing, it's not necessarily one size fits all, even though we're giving general recommendations. So I would say that if you have less than 10% of your body and you are not itchy and it's not spreading, then you probably could keep an eye on it. But it's important you see your doctor so they can verify the same thing.
Thank you. So the next two questions, I believe, are from the same person, and it's regarding. Oh, I'm sorry. Did we get through all of the questions? I might have jumped ahead.
Yes, I did.
Okay. All right. So this person is asking about how cutaneous lymphoma is interacting with Crohn's. So there's two different questions. As someone who has Crohn's as well as stage 1 MF, do you recommend a specialty center? They're finding it hard to coordinate treatment across 3 to 4 doctors, And the next part of their question is just basically how any recommendations on how to balance seemingly competitive objectives between the treatments of the two.
This is actually not so uncommon. Not that the two are related, but that somebody might have a condition that requires an immunomodulatory or immunosuppressive treatment, and they have a lymphoma. So in general, as I mentioned, we want the host's immune system to be as strong as possible. So when I'm speaking to the doctor who's treating the Crohn's, I try and get them to select, if possible, a treatment that won't alter the patient's strength of their immune system, because in theory, that could allow the lymphoma to progress a little bit more. And sometimes it would be probably so much easier, not necessarily that the doctors have to be in the same system, but that they're willing to communicate with each other by some means.
Okay, thank you. On our next one, are there any, oh, we missed, we'll go to, how do you know if MOGA is working?
Well, mogamulizumab, it works really quickly in people's blood if somebody has blood involvement. And you can tell that by, I guess, initially looking at the blood counts and then looking at things like flow cytometry. It works a little more slowly in other areas like the skin. And it's an antibody, so it doesn't work incredibly rapidly like some other things might. So how can you tell if it's working? If somebody has blood involvement and perhaps on a blood count they have a lot of lymphocytes and you see them going down, that would be a good sign. If the flow cytometry has less and less and less cells and sometimes has no cells, that would be a good sign. And then kind of lagging behind, you see the skin improve and the itching, if there's itching, improving as well.
So the second half on that question was, what are some options for next steps if MOGA isn't working?
It would depend on the patient's stage and type of disease. So I would say in my practice, mogamulizumab is used most often in patients with Sezary syndrome or total body redness. And my next treatment option, though there are many, might be something like an HDAC inhibitor like romidepsin, though there's other options as well. And your specific physician would know, in your case, given your overall health and status, what might be the next best choice.
Thank you.
I'm just going to pipe in really quickly that mogamulizumab can cause a dermatitis in a fair number of patients, 20% in the clinical trials, but at the centers in kind of real world data, it's closer to 50 to 60%, and it can look very, very similar to CTCL clinically. So if that, I think whenever you have a rash that's not getting better or suddenly got worse on MOGA, it would be good to see a dermatologist, undergo a biopsy, have it read by a dermatopathologist who is experienced with the nature of MOGA dermatitis, so that you don't prematurely stop the MOGA, and you can treat the MOGA dermatitis with topical steroids or prednisone or phototherapy, or methotrexate, and try to treat through and then still gain the benefits of staying on the MOGA.
Okay, thank you. So we usually get a question about diet. Is there any precautions for a diet or a daily routine? And what we've had is, are there foods I should avoid, not avoid? But what can I do to just overall help?
We're each waiting for the other one to speak. So let's see, diet. I tell people who ask me that question to eat a good diet. Do they need to eliminate all sugars from their system? No. Would it be nice not to eat a lot of processed or fast food? Yep, that's good for all of us. I would want them to get their rest because it helps their immune system. I would want them to try and de-stress if they could, be it walking, swimming, meditation, art, music, whatever it is that distresses someone. We talked about skin routine. What else, Dr. Kim, can you add?
No, I agree 100%. I think there's a lot of information out there on the internet for anti-cancer diets. Some of them from, very from high-profile physicians. And so it's such a common question for patients to ask, and maybe the number one question. And I would say that there's no really good studies or data behind the people who tout a special anti-cancer diet, whether it's low sugar, gluten-free, et cetera, et cetera. I would just follow the sensible recommendations Dr. Pinter-Brown said.
Okay, thank you. This is what the doctors always tell us: be healthy, eat healthy, and exercise. I am stage 1A with a single grade 3 lesion. Can you explain what a grade 3 lesion in accordance with what grade 3 lesion is in accordance with the HODAC system means?
So I think that we probably would need a little more information, but if I had to extrapolate, HODAC, Dr. HODAC was one of the physicians who published about the different grades of follicular or folliculotropic mycosis fungoides. So if a grade 3 lesion means that on biopsy, there is a dense amount of inflammation, of MF inflammation around the hair follicle with destruction of the hair follicle, and that they think is associated with worse prognosis. So this is something that, though I don't think means right now we don't have enough data. We need to follow patients out longer. The way we're using the information of the stage 3 is just to guide treatments, for instance. So a stage 3 lesion may require more than just a topical agent. You might want to do intralesional steroids. You might want to do low-dose radiation therapy. If you have lots of stage 3 lesions, you may need a systemic therapy to treat the CTCL from inside out. But all the decisions we make when we treat patients, it depends on clinical pathologic correlation. So it's not just based on what it looks like on path, but clinically what type of lesion that HODAC stage 3 lesion is. So that is the way I approach it.
Thank you very much. Have you seen patients with minimal skin issues have cancer spread internally to an organ or lymph node? Another progression question.
That would be a very unusual situation. I wouldn't want to say it never happens, but I would say that would be extremely unusual.
Thank you. Has any relationship been found between COVID triggering primary cutaneous lymphoma? Do you recommend getting COVID vaccine whenever recommended by the CDC like it was recently?
So this is a similar question because viruses suppress the immune system. And so just like with stressors, if somebody gets COVID, their skin may flare. And of course, I would recommend that people have COVID vaccination.
Okay. I have cutaneous B-cell lymphoma that presents as small bumps on my head. Do these need to be treated? My dermatologist says only if they become bothersome, which they are not.
Agreed.
Well,
Yes.
It depends on the grade of the subtype of cutaneous B-cell lymphoma. So if we can confirm it's what we call the indolent subtypes of follicular or follicle center cell B-cell lymphoma or primary cutaneous marginal zone B-cell lymphoma, and the usual studies have been done to rule out internal lymphoma spreading to the skin, then yes, I would agree with your dermatologist that if you have a few small bumps that don't bother you, aren't growing rapidly, then active surveillance is acceptable as long as you have close follow-up with your doctor to make sure they're staying small and not progressing.
Okay, thank you. Real quick, I just want to say that we have we have a little under 10 minutes left. So if you have any last minute questions to get in, I know we weren't able to get to all of them, which I apologize, but we've gotten through over 25 of them so far, which is awesome. but the doctors are going to try and answer as many questions as they can. I have been diagnosed with lymphoid papulosis. After diagnosis, I developed other issues, including cutaneous sarcoidosis. I knew I was going to flub that one. Do you see a correlation between LYP and other autoimmune skin issues?
I have not, and I don't think the literature has shown that.
I have not either.
Okay, thank you. Next question is regarding HPV vaccine. Can it be taken if someone has MF?
Yes. So the usual recommendations is that people that have lymphoma shouldn't take live vaccines, but there's hardly any left. So the live vaccines that are left are primarily ones that you would take if you would travel, like yellow fever is an example, or typhoid. There's very few live vaccines left that an adult takes.
All right, thank you. My oncologist recently introduced the concept of a stem cell transplant. In your experience, I'm going to add that in, at what stage in a CTCL MF journey might stem cell transplant become a reasonable treatment option? What makes a candidate suitable for transplant, and what is the success rate?
That's a very difficult question, and I'll take the questions in a different order. So what makes a candidate suitable would be that you have an acceptable donor, that you don't have a lot of comorbid conditions that would prevent a safe transplant. If you could put the question back up, though, it would be really helpful. And the success rate, weirdly enough, the success is higher when someone has Sezary syndrome or erythroderma, meaning that their skin is totally red, versus a patient that has large cell transformation or tumors. And then going backwards, at what stage in a journey would it become reasonable? That's such a hard question. But I think there would be an interplay with the stage or the nature of the condition and what other treatment options remain, as well as the patient's age.
Thank you for answering that difficult question. So next one is, my doctor told me to think of early stage MF as a chronic rash versus cancer. Is this a good attitude to have, or do I need to be more vigilant and check my skin for any changes?
I would advocate for a balanced approach. So this is a cancer, a rare cancer, but it is true early stage disease does in many ways behave more like a chronic inflammatory condition. But there are things you have to look out for. So I would say that you want to have regular follow-up with your trusted doctor. You want to keep an eye on skin changes and take good care of it. But at the same time, it's different than advanced stage disease. So I would say that it's in between the two approaches is what I would do.
Okay, thank you. I've had large psoriasis since childhood. Recent biopsy and IHC has diagnosed as MF tumor stage, no blood involvement, PET CT pending. What should be the next step for diagnosis and treatment? Is a PUVB a potential solution?
I want to echo something Dr. Kim said that's so important in this particular question, and that is correlating what the physician in the office sees with their eyes with the pathologist. So I don't believe necessarily that you can diagnose tumor stage mycosis fungoides solely based on pathology. And it's so important because I approach tumor stage disease so differently from other stages.
Yeah, I would echo that. Sometimes you can have a tumor, what looks like a tumor under the microscope of MF, but when you examine the patient, if the lesion is small, an ulcerated papule, it could be type C lymphomatoid papulosis. that is mimicking it. So it really depends on which dermatopathologist is reading the report and what you look like clinically. But it sounds like since you had blood work and a PET scan ordered, then maybe it was a tumor. And again, if you have one tumor versus many tumors, that also influences the treatment approach. I know we haven't mentioned it so far, but localized radiation therapy is used quite a bit as an effective way to treat, single or few or localized tumors. And we use that quite a lot in the CTCL field.
Great, thank you. And this is going to be our last question. Our hour is almost up. So is flow cytometry a good enough test to rule out peripheral blood involvement?
Well, the problem is lymphomas come from blood cells. Lymphocytes are blood cells. So in theory, even someone with very early stage disease may have a rogue cell that takes a turn through the blood, not that they stay there. So the concept of blood involvement has to do with the amount of cells and whether there's enough there to merit treating the blood specifically. And I would say, if that's the question, is there enough blood involvement that a treatment should be designed to treat that area? Then flow cytometry is an excellent test.
Okay,
I'll add my
thank you.
2 cents about flow cytometry. I think one thing to know is that you can have benign extensive skin rashes sometimes have a false positive low level flow cytometry. So it is not a 100% specific test. Just keep that in mind. There's also ancillary testing like T cell receptor gene rearrangement studies can be done in skin and blood that help you interpret the results of the flow. So what I usually tell my patients is the flow is a valuable test in the right setting, but has to also be interpreted with the other molecular tests, sometimes when it's a borderline result.
Thank you both so much. I want to give an overall thank you, Dr. Pinter-Brown and Dr. Kim, for taking the time out of your busy schedule to join us today to answer all of the questions that you were able to answer. I wanted to ask before we leave if you have any parting thoughts.
Keep asking questions.
Yeah, wonderful questions today. Really wonderful. And I want to wish the Cutaneous Lymphoma Foundation a very happy 25th anniversary. And thank you for all you do for our patients. And I want to thank all the patients here today and those who've submitted questions. Thank you.
Thank you so much. And while I will say thank you to everyone attending the webinar. We look forward to seeing you at future programs. And please take the survey at the end, because if we'd like to know if we are doing good or if we could do better. And have a wonderful weekend, everyone.